I'd like to thank DMA for inviting me to speak today, and it's a pleasure to be here. And I'll try to give a little bit of an overview today on ALS and dementia. In the handout it says I have no disclosures, but I put it up here. I do serve as a consultant for several companies, many companies, I think enough so that I'm not biased in one direction or the other. But there's a lot of drug development happening in ALS. None of which is actually pertinent to the presentation today. I also received research funding from several organizations, including NIH, ALS Association. One of the compounds I will be talking about that are in clinical trials is funded by Biogen IDEC, and so that is the only item that I'll be discussing that's an investigational therapy. So today I'll try to move quickly and try to kind of go over in general terms about ALS and then the current state of treatments, because I think there's some misconception about what's available and how we can impact the disease, because the field in the last 3 years have taken a very fast pace and has shifted dramatically. And that's my area of expertise, is amyotrophic lateral sclerosis, or ALS. And then, of course, in ALS, there's a spectrum. It's now considered a neurodegenerative disease. And in the spectrum of dementia, and understanding ALS and dementia as a syndrome has really opened up the field of ALS, actually. So I wanted to talk a little bit about the current knowledge of the genetics and the pathology, and then the current state of gene-directed therapy. So first, I'll give you an overview of ALS, and no good neurological lecture starts without a picture of a historical picture and a little bit of history. So ALS was first described by Charcot in the 1800s, and then really in the United States we didn't really get more familiar with it in the lay community until Lou Gehrig gives his farewell speech in '39. I'm a Yankees fan, and so my husband's a Boston Red Sox fan, so this is a very big point of contention. And this is the only time they'll let me put Lou Gehrig's picture up there. And we really didn't understand much about this disease. It's a progressive and fatal disease. And we didn't really understand much about it until we identified clusters of families that were affected by ALS. And the first gene that was discovered was in the early 90s, and a gene mutation in the SOD gene. From there, scientists were able to develop a transgenic mice model where we thought we could definitely test a lot of drugs and find a pathologic basis of the disease and find a potential cure. This led to the approval of Riluzole, or Riluzole, it's generic now, in the early 90s, and we thought we're going to definitely have a whole slew of treatments and cures subsequent to that, but it hasn't turned out that way. But it did open a gateway to develop basic and translational research, improve our clinical care and clinical research. So ALS, amyotrophic lateral sclerosis, it's a pathological term. In the US, people say Lou Gehrig's disease. In Europe, they say motor neuron disease. Globally, it's universally referred to as amyotrophic lateral sclerosis. Amyotrophy refers to what you see in the muscle biopsy, which is atrophic muscle fibers, angulated fibers, grouped atrophy, and pycnotic nuclei. The lateral sclerosis portion comes, this is a cross-section of the spinal cord. It comes from the hardening of that anterior and lateral column of the spinal cord, which is then replaced by this fibrous astrocytes, or what's called gliosis. So this often shows up on exams, so I'm gearing up for my board recertification this Tuesday. And so that's where the terminology comes from. And then the epidemiology is being better understood. This is data from the CDC. So the CDC has a national ALS registry that is actually a voluntary registry. So a patient has to actually actively volunteer to enter their data in. So it's not perfect, but it gives us some idea of prevalence. And so the incidence is about 1.6 per 100,000 population across all ages, although that incidence changes as patients get older. There's about 5,000 people that receive the diagnosis of ALS in the United States each year. Prevalence is about 20,000, and it's a little bit more prevalent than men than in women. And the typical age at onset is 55 to 75, so it's a bell curve. So it's different than Alzheimer's disease, because after 75, the incidence kind of drops. So it's really peak incidences between 55 and 75. So what do you see when you see someone with ALS? Well, patients, historically, they'll say, I have this progressive weakness, and it seems to be getting worse. I don't have any pain associated with it. Usually when a physician looks at the patient, they'll have signs, upper and lower motor neuron signs. So lower motor neuron signs include muscle fasciculations, the muscle atrophy and weakness. The upper motor neuron signs are spasticity and hyperreflexia. And these are some examples of what patients can present with. Usually a third of the patients will have slurred speech or speaking trouble, and often they go to the neurologist and they're diagnosed or they're screened for a stroke. Sometimes people can have hand weakness and they're misdiagnosed as carpal tunnel, and they have even carpal tunnel release before they get to an ALS specialist. Sometimes they have foot drop, so that's a third of the patients, and they'll be misdiagnosed as lumbosacral radiculopathy or some lower back problem. Rarely patients can have stooping of their posture, and it really goes unrecognized and it's dismissed as aging. Or sometimes they can have breathing trouble, and they're seen by the pulmonologist and cardiologist first before coming to the ALS specialist. So right off the bat, you can get an idea of how different a person can be individually from person to person, how they present right off the bat, and then the progression is different with each patient. So even though we have general overviews of what the disease is on textbook and reference guides for medical professionals, each person's disease is very different. The diagnosis is a clinical diagnosis. I don't have the luxury when someone comes in, they've already had surgery or they've been told they have other things, they might have been told they have Lyme disease. It's hard for me to tell somebody how I get to the diagnosis. I have to really go through an algorithm, and it's really based clinically on the findings on exam of upper and lower motor neuron signs in different regions. It's based on normal lab studies, normal neuroimaging, and I don't yet have a blood test or an imaging test that can diagnose them, but definitely the community is working on that. And so I just wanted to lay out how there's a spectrum within motor neuron disease in and of itself. So dementia, as you can see, adds another layer of complexity to an already complex disease. And this I just put up, this is from the Packard Center, but in the US and over the years, as we've kind of standardized our care in the United States, as we've kind of improved our interventions and aggressively used supportive therapy, survival has changed. So normally when I get a patient tells me, well, doc, they already told me that I only have 2 years to live and I've got to get my affairs together. But that statistic is not true for many patients. So I myself follow almost 15% of patients. I see 150 new patients per year that live beyond 5 years and certainly beyond 10 years without the use of tracheostomy or a feeding tube. So it is highly variable, and we understand some clinical prognostic indicators. So if they're younger, if they have hand or foot onset, they live a little bit longer. So I would be careful about, if you see someone with ALS, about the survival data, because it's very unique to individuals. So the current treatment landscape, I'll move through this quickly. So there were 2 trials that looked at riluzole. The first trial studied riluzole against placebo, and there was a benefit of 90 days against placebo. The second trial was a dose-ranging study, so they studied 50, 100, and 200 milligrams total daily dose against placebo, and that showed a 60-day survival advantage against placebo. Now, these were studies in the early 90s, and physicians said, okay, well, we don't have anything better, so the FDA approved it in the early 90s. There was some kind of, I think, ambivalence among the ALS clinician community about prescribing it, because it only provided 2 to 3 month survival advantage on average. But the dose is usually 50 milligrams given twice daily. Common side effects are fatigue and nausea. Now, there are newer formulations of riluzole. There's an oral liquid form and an oral dissolving form of riluzole. So the liquid form just got approved the fall of last year, and the oral dissolving form has just been accepted as a new drug application to the FDA to address the issues of swallowing, right? So patients with ALS have trouble swallowing, and they were having to crush the pill, and so there's these new formulations. But this has actually caused the community to revisit riluzole. Is it really that important? Should we be prescribing it? And so there's been meta-analysis and retrospective studies to look at long-term survivors, and more often than not, patients are on riluzole if they are long-term survivors. The other study that caught the eye of the community is this retrospective analysis of that one of the studies that led to the riluzole's approval. When you look at it and apply this new staging system that's still in development called the King staging system, we look to see where does riluzole benefit the patient the most. Because when you say the patients live 2 to 3 months longer, patient asks me, well, is that the first 3 months or the last 3 months? Because I don't know if I want to live longer if you're just saving me the last 3 months. So the study looked at those patients in that early trial, and they saw that in stage 4, so it is the more advanced stage, patients had a benefit of living longer and staying in that stage longer. Now, in this particular study, when you looked at the analysis, because of the inclusion-exclusion criteria for that particular study, nobody was in stage 1, so we can't really understand what happens in stage 1 with riluzole. So do I have any effect on the early stage of disease? But this prompts the community to kind of look more carefully at what the benefits are, and we understand a little bit more about pathophysiology of the spinal cord, and there are transporters in the spinal cord that shift riluzole out of the CSF, so that might be impacting its total benefit. The other thing I should let you know is that edaravone, the brand name is Radicava. This was approved in 2017 in the US. It's approved in Japan and South Korea as well, and there's pending applications in Europe and Canada. So this was a small study, 137 patients, but this was like 5th study for the company that developed it, where they kind of kept doing it. They had repeat failures in ALS, and finally they did a post hoc analysis and saw that rapid progressors had some benefit in a post hoc analysis, and they did the 5th study where they showed that edaravone slowed down the rate of functional decline over time, over 6 months. And that was consistent with the slowing of the rate of decline of breathing and overall survival. So that was the data that was published in 2017. And this is where, I just told you about 2 to 3 months in riluzole. Patients come and ask, oh, so there's a 2.49 point difference in the ALS functional rating scale. What the heck does that mean to me? And so it's a little bit difficult to communicate, but the whole big picture is both of these therapies slow down disease progression, but it's not a cure. It doesn't halt disease progression, but it is what we have. And so this particular medication that was approved in the US is a little bit difficult to administer, so patients need a long-term line, like a PIG line or a tunneled catheter or a port catheter. They get 14 days in a row of infusion over 1 hour, and then they get a 2-week break, and then each cycle they have 10 days of infusion and then a 2-week break. So it's a lot of infusions, especially for neuromuscular diseases, and it's a little bit more of a clinical burden than, say, taking the tablet like riluzole. In addition to the disease-modifying therapies to slow disease progression, ALS management is very important, and it's multidisciplinary. But there's been literature to show that if a patient can get to a multidisciplinary care center, it has an impact on survival and quality of life. Additionally, we use a lot of the supportive equipment, and this has also impact on survival and quality of life. So preventing falls. I always tell people, they're always looking to me. They come and they say, what's the status of stem cell therapy? Can you replace lost nerves? I'm not there yet. And the community is not there yet, but these little things that don't seem like rocket science make a huge difference in somebody's life. So that means preventing falls, maintaining weight, even if you have to use a feeding tube, so it's not for prolonging end-of-life stage, we use the feeding tube as a disease-modifying therapy, even before they lose the full ability to swallow, using non-invasive ventilation like BiPAP and communication devices. And then I'll just touch upon just a couple of things in the field. There's been an update to the clinical trial guidelines. So this was a 3-year effort that I was involved in to update the clinical trial guidelines. Still, it's based more on consensus than evidence, but I'm hoping that will change in the future. It updated different aspects of clinical trials to make clinical trials in ALS more efficient, because we haven't had much success. So number one, trying to improve preclinical studies, improve biomarkers, improve the design of the clinical trials and the outcome measures. So that was just published this month in Neurology, and it's hoped to kind of serve as a guide to help improve clinical trial efficiency and help move drugs faster in the pipeline. The other thing that's occurred in the field is that the FDA has taken notice that drug development needs to speed up in ALS. They've actually done multiple patient meetings in 2013, 2016, 2019. And they also issued a draft drug development guidance in February 2018. It's not perfect by any means, and there's some areas of alignment with the clinical trial guidelines, but there's still some gaps, because they still consider survival as an endpoint, which it would be a very long study and require lots of patients. So you're going to hear more about that and likely more publications in the upcoming year. So ALS and dementia. Traditionally, ALS was considered a neuromuscular disease despite having upper and lower motor neuron involvement. However, our understanding of the clinical presentation of ALS has identified that 50% of patients right at the time of diagnosis have some cognitive or behavioral impairment. Now the thing is, sometimes it's hard to screen because people can't speak right off the get-go. So it's hard to kind of pick up any kind of cognitive or behavioral changes. And then the discovery of the C9orf72 gene. This is a major gene and a major player in ALS. So 40% of familial ALS and 7% of sporadic, meaning patients with ALS who have no family history carry this gene. So it was the first time we're able to kind of link familial and sporadic ALS. But understanding ALS and dementia, or frontotemporal dementia to be more specific, has kind of helped us understand that ALS is a syndrome. And it's on a spectrum of neurodegenerative disorders. So this is just a picture to kind of help you understand that spectrum. So ALS, classic ALS, if they come in and they're diagnosed and don't have any cognitive or behavioral changes, likely they'll roll through the course without any kind of cognitive or behavioral issues. But there are some, about 50%, that'll fall into this ALS with some cognitive or behavioral changes, but do not fulfill the criteria for FTD. Then there's the ALS which then can be subtyped into behavioral variant, which is actually the more closely linked one to ALS, versus the primary progressive aphasias, which have very specific neuroanatomical correlation. This is just from an article from 2017 from Nature Reviews, just to highlight really how many genes we've discovered in ALS, and C9orf72, C9orf, or I'll call it C9, has been a major player, but each year just doubles. So we've kind of exponentially increased our knowledge of the genetics, and it's made it more complicated actually. So what we kind of naively classified as familial and sporadic ALS, it can't really be done that way. What we've realized is that there's many different genes that kind of present as ALS or present as other neurodegenerative disorders. They have motor symptoms, extramotor symptoms, and they have different pathophysiological mechanisms and different subtypes. So classic ALS with bulbar, or speaking swallowing difficulty, or spinal onset, arm or leg weakness, with cognitive or behavioral component fulfilling the diagnostic criteria FTD makes up about 5 to 15% of patients. And like I said before, the ALS patients most commonly have behavioral variant of FTD, and the symptoms are usually apathy and loss of sympathy. It's hard to pick up because in ALS we don't have a really good screening tool. Semantic aphasia can also be seen, but the non-fluid variant and the logopenic variant of aphasia or speaking difficulty are very rare. And it's prompted the field to ask for family history. We used to ask, do you have any family history of neuromuscular disorders? We've had to shift the way since 2010 and ask for history of dementia, Parkinson's disease, psychiatric disease, suicide or addiction. And these are often associated with the C9orf72 gene. So as I mentioned, 5 to 15% of patients who fulfill the criteria for ALS fulfill the criteria for FTD. But up to 50% can have cognitive or behavioral changes. Now, FTD, so about 13% of FTD patients who fulfill the clinical criteria will subsequently fulfill the ALS criteria. So it's more common to see it the other way around. And then mild to motor neuron involvement is seen in 40% of patients with FTD. So the diagnostic criteria, so there is a frontotemporal dementia clinical criteria, and it's applied to patients, but it's also applied the same way to ALS patients. But if they don't fulfill it, we in the ALS community have subdivided ALS into ALS with cognitive behavioral components into 3 categories. So there's ALS with just the behavior component, there's ALS with executive dysfunction, and then there's ALS without executive dysfunction, and this usually involves memory impairment or visual spatial impairment. So this is hard to read probably, but this is the criteria for FTD. So once you see FTD, you either subdivide it to aphasia or behavior variant. If it's aphasia, you have subcategories for defining it as semantic aphasia, non-fluent aphasia, or logopenia. This is the Ellis-Scorial criteria. So I'm putting these up here just to show you how difficult it is to kind of fit patients into a diagnostic criteria. It's all based on clinical observation. So again, you have to count up the regions, bulbar, cervical, thoracic, lumbosacral, and count up the areas that have upper and lower motor neuron signs for diagnosing ALS. I have to tell you, many patients never actually reach definite ALS. They die before then, so this criteria is not clinically useful, but it's helpful to kind of create a similar population in a clinical trial. In FTD, like I said, there's different criteria for the frontotemporal cognitive and behavioral syndromes that occur within ALS. And these are kind of the ways that we do it. So you can see the ones that don't fulfill the frontotemporal dementia clinical criteria. There's bits and pieces of the behavioral screen, the executive function, and non-executive testing that they have to carry. So we don't have good tools. The classic testing that we use for neuropsychological testing isn't really helpful in ALS because most of it relies on speaking and writing. And in ALS, patients have motor deficits that make it very difficult for them to write or very difficult for them to speak. And so I have to tell you that I think in the ALS community, we miss many patients at diagnosis that have cognitive or behavioral impairment. And the symptoms that patients with ALS and concurrent frontotemporal dementia often involve apathy and loss of sympathy, but they often have fluency difficulty, language difficulty, social cognition difficulty, executive dysfunction. This particular impairment is associated with a rapid rate of disease. So ALS patients with executive dysfunction usually progress pretty rapidly and follow that 2 to 3 year survival course, and memory impairment. So the impact, when patients have this, it's really difficult and really complicated. It's often associated with a gene. So just imagine, patient comes in, they're weak. Normally in our world, they come in because of weakness, not so much because of the cognitive issues. The cognitive issues usually secondary. So they come in with weakness, the caregivers are already struggling with the patients. They come in, so I have to explain a complicated clinical diagnosis of ALS. Then if I pick up that they have frontotemporal dementia or symptoms of frontotemporal dementia, I have to explain this based on clinical exam. Then, subsequently, I have to explain that it could be related to a gene, and the C9orf72 gene is an autosomal dominant inherited gene. So immediately, when I discuss this, family members get concerned, and the first degree relatives, the parents, the siblings, and the children are at risk. So you could just imagine it's a very emotional visit. And these types of patients have a very aggressive course. So it's difficult because when we explain, the caregivers want to initiate non-invasive ventilation, want to provide feeding tube support for patients who are not eating properly, but there's heavy non-compliance among patients with FTD and ALS. And of course, this increases caregiver burden. I didn't show you, I should have slowed down on the multidisciplinary slide where all the specialists are. One thing that's a gaping hole in multidisciplinary care is neuropsychological support. We don't have enough neuropsychological support. It's not part of our practice parameters because the last time we updated them was 2009 and we discovered this gene 2010. So we don't have enough neuropsychological support within the clinics, and then definitely not enough for the caregivers. And just the last few slides here, in ALS with cognitive impairment or FTD, there's a common pathology which is TDP-43. The reason why I put this here is because it helps us kind of gauge how to target for drug development and drug therapy. And of course, ALS FTD is associated with the C9orf72 gene, although there are other genes implicated in cognitive and behavioral impairment that occur in the setting of ALS. Now, I'm going to highlight just C9orf72 since it's the most common gene. There's been several papers that identified mechanisms or pathophysiology that might be related to that repeat expansion. So in the C9orf72 gene, there's a hexanucleotide repeat expansion, HRE. And what that does is it creates less numbers of normal C9orf72 mRNA and protein in the brain tissue of patients. This is associated with disease. It also creates what's called RNA foci, which traps other RNA molecules and RNA binding proteins, and thereby affecting that RNA biology. But the biggest and most dominant hypothesis is that that repeat expansion on that gene causes abnormal toxic proteins to be transcribed. And so what happens is, depending on the frame and the direction in which the repeat is read, that repeat expansion encodes several short dipeptide repeat proteins that have toxic properties. So this is just to highlight that on the top there, we have patients of different colors, and that means they're different clinical phenotypes. So one of the reasons why we think drug therapy or drug development has failed in ALS is because we're grouping a whole bunch of different patients with different pathophysiological mechanisms and trying to test one drug that targets maybe one of those pathways. So we've tried separating them according to clinical features before we understood the genes, right? So we can maybe group all the bulbar patients with speaking difficulty in one group, people who have leg or arm weakness in one group, or FTD, but still you'll capture people with different gene mutations. So the genetic understanding has helped us kind of subgroup patients. And so I highlighted there the green group, which is the C9orf72 group. And knowing that genetic mutation and that subgroup, we're able to target, and understanding that it creates, that gene mutation creates toxic proteins, we're able to target drug therapy specifically to block that toxic protein. So right now, this month, there is a study that's going on here in New York, and as well as 10 other institutions internationally, phase 1 multiple ascending dose study to assess the safety and tolerability of an antisense oligonucleotide targeting the C9 gene mutation. So the drawing there is just to show you how you have DNA is transcribed to mRNA, and then it's translated to a disease-associated protein. The therapy that we're testing in clinical trials right now in phase 1 is to stop that mRNA, that toxic mRNA, from producing the toxic protein. And so this is no easy task. You know, we've already dosed, I've dosed one patient already. It requires doing a lumbar puncture and infusing the gene-directed therapy into the spinal fluid, and then trying to follow the patient along, so there'll be multiple doses. We have a restricted number of slots right now, but once we understand safety, this will be something that will be expanded into a larger cohort. And so I just will leave this here. This is just different ways of targeting therapy. So gene-directed therapy is one of many kind of approaches. This is our pipeline. That's just the tip of the iceberg. But this is what we're facing with without therapy to kind of stop or cure the disease. And going forward, it's likely these gene-directed therapies. So there's one in SOD, there's one in C9, and we know that this kind of approach has worked in spinal muscular atrophy. So it's likely that within our lifetime, we'll see game-changing therapy for ALS that's caused specifically with gene mutations. So with that, I'll just end it. Yeah, this is our multidisciplinary clinic and our research team. It takes a village, basically, to take care of ALS patients, just like in prevention. So thank you very much.